dead simple. Large range, yeah? Up for 1, squeeze for 1. 3 seconds. So, then the load progressions are ankle weights on the bottom leg, okay?
But there is not a clinical test that can rule in hip-related groin pain. Okay, and then to do the eccentric testing, you just get them to do a 3-second isometric and a 2-second break. So go ahead, push, 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 push. Yeah,
I think we need to look at the biomechanics. I think what Jeff was saying yesterday is absolutely pertinent with regard to we can look at pathology, but what's the mechanical link to that? What do we do wrong biomechanically? But if someone's got an immature pelvis there, particularly if they have a little bit of pain and you're doing high loading, like a Copenhagen, I find that it may be provocative for some of those.
Worse? Everywhere? Right. Is it hip or is it SI? Let's block it. What have we got now? It's better? Markedly better. Like big fish difference. You've often got an adductor enthesopathy with a pubic symphysis instability. And so you want to do some higher level loading for the adductor tendon part of it, but they may not have the stability to do that in closed chain. So you may push the higher tendon loading out of the gravitational field in supine for a while you're building your pelvic stability.